All right, take it away.
All right. Hi, everyone. Welcome to week 2. I'm just going to go straight into upper limb 2 and not waste too much time with introductions. Just as a bit of an aside, during the musculoskeletal exam of the shoulder and sort of the overview, I will be, so like Jane will be the one covering that. I will be going into his room since we live in the same house, and he will be demonstrating some of the tests and stuff on me. So look forward to that. Get hyped for that. It'll be at the end, so please stay tuned. I'm going to start with upper limb 2. It's not as heavy as what we did last week with shoulder. But I think once you get down to the forearm, you start to appreciate that the number of muscles and things you have to remember really does increase a lot as you go down towards like areas that are more dexterous. So like when you get down to the hands, you'll see what I mean when there's so many different muscles happening. The forearm is no exception. There's all these different compartments that you need to think about, as opposed to the shoulder, which kind of just has areas with different attachments and things. So I would really encourage you guys to sort of take this session as a bit of a like sit back and relax and just listen to what I'm saying instead of taking notes. Because what will happen is that you'll have specimens, imaging, PACA tutorials, you'll have lectures and things, all those things happening in the week. That'll be a chance for you to actually consolidate everything that I'm saying. So at least you've heard of it once and you know that, this means this means this when it comes up during a tute or something like that. So just take it a bit relaxed. If you do have any questions though, let me know in the chat. We'll get started. So I've kind of structured it a little bit differently to what we did last week. I've kind of tried to make everything a bit more color coded so that when you look through the slides, you know exactly where bones are happening, muscles are happening, and so on. So keep this as a bit of a legend for yourself. Today, we're going to be covering upper arm and forearm. So there will be some things in the wrist that we're not going to be covering yet. That's going to be for next week. Just as a bit of an aside, if you don't know what the upper arm and forearm are, here's a diagram on the side. So we covered shoulder, upper arm, forearm, and then hand will be next. Now, as a disclaimer again, the information on this presentation is not going to be like complete. It's not going to have every single thing you need. In fact, it's probably like 30% of your teaching because the rest comes from specimens and imaging where you actually get a spatial understanding of where everything is located. This is more for information. So if you want to know about a specific muscle and what it does, you can refer to these slides. And I'll also tell you where I got some of this information from as well, so you can refer to the primary source. I've also put boxes on each of the slides, or not each of them, but some of the slides where I think that there's a useful memory tool that I use for my exams, because there's a lot of information and you're not expected to remember every single little detail. But if you remember what's in the box, which is going to have like a mnemonic or a story or something for you to remember, that'll be really, really helpful for you when you just have a mind blank because of the adrenaline rush during the exam. That's just a brief introduction. Before we get started as well, because I'm going to be talking about a lot of different terms related to motion, I just wanted to go into some of basically the different motions that you can have or movements you can have at the shoulder, because some of the upper arm muscles actually have motion at the shoulder, but also the forearm and some of them at the wrist and fingers as well. The fingers are probably not so important, so maybe ignore this top right one with abduction, adduction of the fingers. But it's really important to understand everything about flexion, extension, adduction, abduction, medial rotation, lateral rotation, flexion, like everything else that we've discussed from last time, circumduction as well. The one that confuses a lot of people is the motions at the wrist. So abduction and then adduction. Whenever I forget which of those is which, I always remember that adduction is something that brings that part of the body closer to the midline or closer to the rest of your body. So if you think about adduction, it should be something that, like if you think about these hands, if you adduct them, then you should be bringing them closer like this. So it's coming closer to the middle of my body. Same with your shoulders, or same with your arms. If you adduct them, you're bringing them closer to your body. I'm not sure if you guys can see my hands and stuff, but bringing them closer to your body. And then abduction is just going to be the opposite. So it makes it really, really simple. Although one thing I will say is that we don't really use the terms abduction, adduction when it comes to the wrist joint. We usually just say ulnar deviation and radial deviation, and we'll understand what that means when I go into the bones of the forearm. Okay, so that's just a brief introduction so that you understand some of the terminology. But now let's actually get started into the upper arm. Upper arm is not going to take very long. There's only one bone in the upper arm, it's the humerus. We already went through some of the I guess the landmarks of at least the proximal humerus, because it was relevant to our study of the shoulder. So you know the greater tuberosity, where it's the attachment of all the rotator cuff muscles except for subscapularis. We can kind of remember that because subscapularis happens sort of at the front, right? So it's going to be attaching to the lesser tuberosity that's sort of more anteriorly located, whereas every other muscle is sort of at the back. So it's going to attach to the greater tuberosity that's closer to there. And then so counter example, lesser tuberosity is just where the subscapularis attaches and nothing else. We've also got the intertubercular groove. The ones near the bottom are sort of less significant. So the intertubercular groove is just basically between the two tuberosities, and that's where the long head of the biceps travels through until it goes down to the forearm and the upper arm. The deltoid tuberosity is just part of the deltoid insertion. I think James mentioned last time that the deltoid muscle is massive, so it attaches to all these different bits. But on the humerus, it's just attaching to the deltoid tuberosity. Actually, what I might do is I might get a pointer. There we go. So unless if you couldn't see my mouse, then at least you can see the pointer. So the deltoid tuberosity is down here. And then the radial groove, this is probably the most important one apart from the tuberosities, because when we come to the clinical relevance section at the end, you will see that it actually carries or conveys both the radial nerve and the profunda or the deep brachial artery. So if this part is damaged for whatever reason, usually due to a fracture, then we might get damage to the radial nerve and profunda brachii artery. And I'll go into the clinical significance of the radial artery later on as well. Okay, so that's the proximal humerus. Are there any questions in the chat? If there's any questions, please let me know, guys, because I can't see the chat right now. So that's the proximal humerus. Now the muscles are actually, so you will see this in the upper arm and the forearm. They're divided into compartments. Now, whenever I say the word compartments, it's actually, the reason why they're separated into compartments is because they're separated by this thing called the deep fascia. So you've got superficial fascia underneath. So you've got your skin, and then you've got subcutaneous fat, then you've got superficial fascia. And then underneath a couple of layers, you've got the deep fascia. And what that does is it separates all the different muscles based on their relative function. The reason why we have these fascia in the first place is there's multiple reasons, but it's also to ensure that when I'm contracting and relaxing all the muscles at different times, that all those muscles don't just pop out of their compartments, which would be really annoying. So it keeps them sort of invested. So sometimes it can be called investing fascia. And you can see in this diagram up here that deep fascia, there's different names for it. So we've got the medial one, we've got the lateral side. That's not so important, but it attaches down to the humerus. You've got the anterior part, so near the front, you've got the posterior muscles near the back. This is super useful because it sort of shows you that the anterior compartment will have a specific function or shared function, and the posterior compartment will have a different shared function. If you want to refer back to these slides for pictures of the muscles, so this would be the posterior compartment of the upper arm, which actually only contains one muscle, whereas this is the anterior compartment of the upper arm as well. So refer back to these slides for pictures. But let's go into the specific muscles. The anterior compartment and posterior compartment of the upper arm are really, really simple. You've probably heard of these muscles before. So the anterior compartment is generally going to be things that are going to flex. So whenever you think about anterior, think about flexing. And that can be either at the shoulder joint or it can be at the elbow joint. The reason why is because some muscles will actually go across both joints, whereas some muscles will only transverse one of those joints. So think about biceps brachii actually has more than one head, and it travels from your shoulder joint all the way down to your elbow joint. So it can actually cause both shoulder and elbow flexion. This actually makes it more prone to damage as well, just because it's going over two major joints. And if you're doing a lot of motion in these areas, it can lead to increased risk of damage to the tendon, or it can lead to even detachment of the tendon. So there's actually a sign called Popeye sign, which I haven't included because it's not actually too relevant. But when you have lack of attachment of the biceps because it breaks off, you can actually get the biceps rolling up in your upper arm. And it can actually look like, so if you've seen Popeye, you'll see Popeye has like massive muscles. So it looked like that. Another thing that it can do is forearm supination. So because of its attachment past the elbow, supination is probably something that I haven't discussed, but remember that supination is where, imagine you're holding a bowl of soup. So you're holding your hands up like this, you're holding that bowl of soup. Whereas pronation is the opposite. And that's like sort of, I imagine it as playing the piano. So P for piano. So it's going down like this. So the biceps actually causes supination as well. It's probably it's an extremely powerful supinator, aside from being a flexor as well. Okay, so that's really important to remember. Now, coracobrachialis and brachialis are smaller muscles, and they go only mid or like across one joint. So coracobrachialis, as the name suggests, actually starts at the coracoid process of the scapula, and it goes down to only midway down the humerus. So usually it'll only lead to flexion of the arm. So not anything really at the forearm, but more at the arm. It causes flexion and a bit of weak adduction, but I would mostly focus on the flexion part. And then brachialis, if you think about, so coraca brachialis was the top half. Brachialis is sort of the bottom half. Okay, so I really encourage you guys to look at the pictures because it'll really help. Brachialis will go to the bottom half. And so it doesn't really do much at the arm or the shoulder. It does more things at the elbow where it causes flexion. Now, all of these muscles, so this makes it really easy to remember. All of these muscles will be innervated by musculocutaneous nerve, which is C5, C6, C7. If you don't remember what musculocutaneous nerve is, just remember to look back on last week's slides where we went over the brachial plexus. That'll show you that musculocutaneous nerve is like one of the upper nerves that comes off the brachial plexus, and it carries the nerve root C5, C6, and C7. The posterior compartment is very easy. So you've heard of the triceps, or in this case, triceps brachii has, again, more than one head, but it does mostly just arm extension. So it's the opposite of all the muscles that are in the anterior compartment. And one common theme you'll notice is that usually most of the muscles that are located on the posterior compartments of the upper limb are going to be innervated by the radial nerve, mostly all of them, which is going to be C5 to T1. Basically, all the nerve roots of the brachial plexus actually go through the radial nerve. It's kind of in the middle, so it takes in everything. Okay, so that's the anterior and posterior compartments, very, very simple. Now going down the humerus, just to have a look at its distal sort of component. We're going into the forearm now, so this is kind of focusing a little bit on the elbow section. We've got the epicondyles, which is still part of the upper arm, and the epicondyles are going to be these sort of projections on the side. So you've got a lateral epicondyle and a medial epicondyle. You can feel those right now if you want to. I have a jacket, so I can't really show you, but if you just like take your hand like this and then put it across your elbow, you might be able to feel two really, really lateral projections that come across. Those are your epicondyles, okay? Above them is actually a ridge. So if you look here, you've got these lateral supracondylar ridge and you've got a medial supracondylar ridge. There's a supracondylar line that goes across both of these ridges, and that is a clinically relevant. So bookmark that in your mind for now, but it's not really significant anatomically, at least from what I remember. We've also got the capitulum and the trochlea. So there's different spellings of this. Sometimes they call it capitellum or something like that. But it's basically the point of articulation between the humerus and the two forearm bones, which we'll discuss are the radius and the ulna. Okay, they happen at different parts of this sort of articulation portion. And there's all sorts of different ligaments and things that are held in there to support that particular joint. We said the shoulder was extremely mobile, but also risk of like sort of dislocating, and it's not very good in terms of stability. The same thing goes for the elbow. Maybe not so much because you don't have the range of motion, but it is still at risk of being dislocated or fractured. So it's important to have all these ligaments there surrounding it. And then finally, you've got the olecranon fossa, radial fossa, and coronoid fossa. I grouped them together because like while they are separate spaces, so you've got coronoid fossa, you've got olecranon fossa, radial fossa somewhere else. Can't see it here. Oh, there it is, radial fossa right there. They're actually just spaces. So what they do is they allow, like if you think about the other two bones in your forearm, which we'll go into next, whenever I'm flexing my arms, I want to make sure that there's enough space for the parts of the more distal bones to kind of fit in and lodge into my humerus so that they're not actually like rubbing against each other every time I'm flexing or extending. So if you think about the olecranon fossa, that's kind of useful for space when I'm extending. So that means that the bones in my forearm are going to fit into that olecranon fossa when I'm extending. When I'm flexing, the bones will fit into the radial fossa and the coronoid fossa. That's basically their main function. They're also filled with a bit of fat and stuff. So it's a bit of a cushioning. Okay, hopefully no questions so far. Now the two bones in the forearm, the radius and the ulna. There's a lot of different bits of these, like you can see the diagram there, it's been labeled in all sorts of different ways, but I kind of identified really just four main bits that are useful for you to know. The radial, so just to give you a bit of an idea, you've got the radius and the ulna. The radius, anytime you think about the radius, you want to think about the bone that's closest to your thumb. So in other words, it's more lateral. So whenever you forget where the radius is, just remember my thumb, it's going to be on that side, whereas the ulnar is going to be on the opposite side. So you can see the radius it sort of starts, it's pretty big, like compared to the ulna. It's a pretty thick bone. It's a little bit shorter. That's not too important, but it is really, really big. And between them, you've got an interosseous membrane, which actually, it allows for them to be attached, but it also conveys like arteries and nerves, which we'll go into later. So these are some useful things just from the outset. The radial head and also the olecranon, those are sort of places that of articulation. So we'll focus on the radial head. That's the part that, as I mentioned, the capitulum, it's the place that articulates with that large capitulum. So it's like a sort of a ball place there. And it also articulates at the ulna at the PRU joint, which I'm going to go into next. So it's the proximal radial ulnar joint. And you can sort of see that here, that they don't just articulate with the bones that come before, like the humerus, and the bones that come after, which are in the wrist, like the carpal bones. They actually articulate with each other as well at 2 points, the proximal and distal radial ulnar joints. And what's really interesting is if you try and take your arm out, I probably shouldn't be saying this now, it's on the next slide, but it's really interesting. If you take your arm out right now and try and do pronation and supination, so just hold it straight, pronate, supinate, and you feel your bones, if you try and feel your radius, you'll notice that it's actually the one that's rotating around the ulna. If you hold your ulna, it's just staying kind of fixed. What's happening is the radius is moving around it. So those are the joints at which that motion is allowed. And it's also the reason why it's called the radius, because it actually forms a circle motion around the ulna, like a circle, right? So that's why it's called the radius, the other one's the ulna. Just if you forget which one is which. The radial tuberosity is the place where the biceps tendon inserts, and that's actually what allows the biceps to exert its supination effect, okay? So it attaches to that radius, and if you just think about pulling on that muscle, and if you imagine where that muscle is going to be attached, it's going to be attached to the lateral side, right? The radius. So it's attaching here. If I pull it, then it's going to supinate my arms or my forearms a little bit. Okay, it's a very, very strong supinator. Ulnar olecranon is really simple. It's just the palpable part. So at the back, basically what you call your elbow is mostly composed of the olecranon. Okay, and it slides into the fossa when you just extend your arm out. And finally, styloid processes, we'll go into this when we get to the wrist, which is next week. It articulates with the bones of the wrist, which are called the carpal bones. Okay, really, really simple again. Hopefully not too much for this time in the morning. We'll get to the muscles though, so that'll be a bit of a shocker. Now, the elbow joint, it's not just one joint really, it's kind of like 3 different joints, some happening closer than others. First, we talk about the elbow joint, and it's really just important to remember the motions that are occurring. So they're both synovial joints, which means they consist of the synovial membrane, which produces the synovial fluid. Hopefully you guys have gone over this with some of your lecturers, or at least maybe last semester. At the elbow joint, you only get flexion and extension. So if you just think about that joint, you only get these motions, okay? There are a couple of components. If you want to search up in a bit more detail, you can. I don't think they're particularly high yield. You've got the joint capsule, which is the one so under the joint capsule, you have the synovial membrane and things. You've got the annular ligaments, and you've also got the medial and lateral collateral ligaments. This is something that you will definitely do in lower limb. So the MCL, LCL, it's not really too important for our studies right now with the upper limb. As I mentioned, the radial ulnar joints, you've got the proximal ones. So over here, you can see, so remember this is the humerus, just to orient yourself, humerus, and these are the radius and the ulna. You've got the radial ulnar joint, which is just attaching between both of those bones, either at the beginning or near the end. And these are the joints that allow for pronation and supination really nicely. It's why it's called a pivot joint, because the radius actually pivots around the ulna. And these ones will include the ulnar and radial collateral ligaments, which again are not so important, but obviously all of these will be it'll be really important for a surgeon because they can be broken during all sorts of different ranges of movements. So keep that in mind. Okay, now the muscle compartments of the forearm are a little bit more complicated. I want you to sort of ignore this diagram, or like at least this section of the diagram for now. The mobile WOD. So like if you think back to the upper arm, you've got the flexor compartment, or you've got the anterior compartment, you've got the posterior compartment. Anterior usually flexes, posterior usually extends. The mobile WOD is more for like surgeons, like it's just a particular set of muscles that have a common origin, common function that they use as a landmark. Just ignore that. But they're also separated by the deep fascia. And again, all these will have different names depending on where they're located, which bone they're attaching to, so the ulnar or the radius. And this box is basically, if you forget everything that I go into in the next couple of slides, just remember this. The anterior muscles will perform mostly wrist flexion because they're going to be inserting down into different parts of the wrist, most of them. And they're going to be innervated by the median nerve mostly, but some of them will also be innervated by the ulnar nerve, which I'll go into later. The posterior muscles are much simpler. They're going to do wrist extensions. Remember, flexion, extension is going down. These are going to be mostly innervated by the radial nerve, like the upper arm and even in the hand. So I don't want you to get too scared by these tables that I'm going to show you. I already said that there's anterior muscles, and remember in upper arm there were only three. The annoying thing is that with the anterior muscles of the forearm, there's actually different layers. You've got the superficial, the intermediate, and the deep layer. As I said, most of them innervated by the median nerve. These are all the muscles and their actions. I really just want you to not memorize, like if you want to definitely memorize all these different muscles and all the different attachments and stuff, if that's something that you find useful. But I would just really remember what each of the different parts of these names mean, because they're in sort of a different language, right? Like flexor, carpi, you've got ulnaris, but they all mean different things, and they just give you hints as to what that particular muscle does. So flexor, of course, means it flexes. Carpi, we'll go into this next week, but these are the carpal bones. So it's going to attach mostly to the carpal bones in the wrist. And then ulnaris means it's going to be on the ulnar side. So remember what I said, radial side is closer to your thumb, so closer to the outside. Ulnar side is closer to the inside, right? So that's going to be the ulnaris. And so if you think about, okay, it's going to flex, which means it's going to cause wrist flexion. It's attaching down at the wrist because it says carpi. It says ulnaris as well. So it's going to be on the inside of my hands, which means when I pull it, it's going to pull like this, right? If it's attaching here, it's going to pull down like this. That's what we call adduction. Remember, adduction is bringing it closer to me, bringing it closer to my midline. Or I can also call it ulnar deviation if that's a bit confusing. We've got palmaris longus. Palmaris, it's in the palm. It's going down to most of the palm or most of the fingers in the palm. And longus just means it's quite long. So if that doesn't really help too much, but you know that it's going to usually be a flexor. So it's going to be wrist flexion. Flexor carpi radialis, I won't go into. It's the same thing as the first one. Pronator teres. Pronator, of course, it's going to cause forearm pronation. I think teres is just the shape. So it's like a sort of smaller, I don't even know what to describe it. It's a smaller shape, basically, like a strip of muscle. Underneath the superficial muscle, so this is when you're dissecting. You remove all the superficial muscles and you go down deeper, you've got the intermediate muscles or muscle. There's only really one. Some textbooks just say that this is a part of the superficial or the deep compartment, but here we've identified it as intermediate. It's the flexor digitorum superficialis, clinically relevant for when you go into clin skills, but not so much for anatomy. Flexor digitorum goes down to all the digits, it flexes them, and it's superficial, or like basically intermediate to, or it's below all the superficial muscles. Wrist flexion, MCP and PIP flexion, like come back to the slide when you finish wrist, all the wrist movements and all the joints. But these are going to be some of the joints that are in the fingers. So the metacarpal phalangeal joint, and you've got the proximal interphalangeal joint, and they cause flexion at those joints. Two boxes here for you to remember. The only muscles that are actually innervated by the ulnar nerve and not the median nerve will be FCU plus half FDP. FDP is not here on this slide, so that's flexor digitorum profundus, that's the next one. But flexor carpi ulnaris, so just this first one here, is going to be innervated by the ulnar nerve. Super duper easy to remember because it has ulnaris in its name, okay? And then half of FDP, which we'll go into next. Also, if this is something that I used, I'm not sure if it was actually useful for anyone else or if it's even that difficult to remember, but I used to always forget what the muscles of the superficial compartment were from like lateral to medial, medial to lateral. The way I remembered it is from medial to lateral, we go pass, fail, pass, fail. Not that, you want your exam scores to be like this, but if you remember it like that, pass, fail, it's going to be pronator teres, flexor, palmaris longus, and another flexor. We'll go into a diagram of what this looks like later as well. It's just super easy to remember. Then we've got the deep muscles. There's only three. So hold it in there. We've got flexor digitorum profundus. Same as flexor digitorum superficialis, except it's deeper. And it also goes a little bit more distally. So it goes down to a couple more joints. So it causes a bit more distal flexion as well, in addition to like wrist flexion movements that all the muscles do. Flexor pollicis longus, flexor, flexing. Pollicis is another term for the thumb. So this is the one that's going into the thumb. And it's also a long muscle. So it's going to cause all the flexion movements in the thumb, in this case, the interphalangeal and metacarpal phalangeal joints. Again, just ignore those terms for now. Pronator quadratus, really easy, pronation. And quadratus means it's in a sort of quadrangular shape. So it's a fairly large muscle if you have a look at it under dissection. And here's just a little bit of a legend of some of the words that you should be familiar with, not just for now, but for lower limb as well. Again, a reminder that these are the muscles by the ulnar nerve, and half FDP is just the half that's closer to the ulnar side. So again, super easy to remember. Okay. And a low yield bit of trivia. This is not something I remembered, it's just something I saw. So the FPL, flexor pollicis longus, and the pronator quadratus are innervated by the anterior interosseous branch of the median. Remember the interosseous membrane between the radius and the ulna? You got like branches of these nerves and also some arteries traveling through the interosseous membrane. They're called anterior posterior interosseous nerves and arteries and veins. So these two muscles are just going to be innervated by the anterior part. I wouldn't remember it, just interesting to keep in the back of your mind. All right, so here's a couple of pictures, and also, okay, first I'll go into this picture. We've got the superficial compartment, all the muscles. We've also got biceps coming down because I showed you the point at which it inserts into the radius, right? So it kind of tells you how it causes supination if you just imagine pulling on it. What are some interesting ones? Yeah, I don't think, if you just have a read of this diagram, you'll kind of be able to justify those motions that I described previously in your mind as to if it contracts, it's going to cause this. If you dissect all these out, you're going to get your intermediate compartment, which is just one muscle, flexor digitorum superficialis. It actually has sort of two heads, but it's not so important. All that's important is that it goes down to kind of midway through your fingers. So it's not quite near the end, but it goes midway through your fingers. If you compare that to the deep muscle, which is flexor digitorum profundus, that goes all the way down to your fingers. That's going to cause more distal flexion. So keep that in mind for clean skills. And this is the tip that I was telling you. If you just take your arm out and extend it out, and you take your other hand. Sorry, this is like blurring out a little bit, but if you look at your forefingers, put it across like this, yeah, and then you think about pass fail across from medial to lateral. That tells you where pronator teres, flexor carpi ulnaris, palmaris longus, flexor carpi ulnaris are all going to be located in that sort of direction. Okay, that's more for anatomy dissections if you're forgetting which muscle is where. Awesome. I can see the chat has like 32 messages in it, but I probably won't be able to see it now. So I'll answer all those questions near the end, if there are any questions. You've also got posterior muscles. So this might be a little bit more difficult actually, because there are a couple more muscles. They still have superficial and deep layers, which is very annoying, but they're all innervated by the radial nerve. So it's not actually too much to remember. Remember, these are all going to be the nerve roots, basically all the nerve roots of the brachial plexus, C5 to T1. Superficially, you've got similar named muscles, but you've got them just starting with extensor because it's indicating that they're all going to cause wrist extension, or even some of them causing elbow extension. So keep those in mind. The main difference is actually going to be the types of muscles. So some, like with extensor carpi radialis, you've actually got a long version and a short version. So if you look in dissections, you don't need to be an expert in which one is which, but if you focus too closely on the wrist, you might not be able to tell which one is the longest and brevis. You might need to zoom out a bit and see like which one actually travels all the way up the forearm and which one sort of just ends near the distal part of the forearm. One of them is going to be longest, one of them will be smaller, which is brevis. These are just going to cause extension and adduction. Extensor digitorum, very much the same as flexor digitorum, except we don't have superficialis and profundus. We just have one. It's going to cause extension of all the joints in only the 4 medial fingers. Okay, let's keep that one in mind. The reason why I say 4 medial fingers, so that's basically everything excluding your pinky, is because there's a really cute special muscle for the pinky, which is called extensor digiti minimi. My favorite one because it has the weirdest name and also the easiest one to remember. So it's the smallest digit that you have, which extends only the little finger. Carpi ulnaris, I won't go into this. It's the same as carpi radialis. Anconius is a bit of a strange one, but it's actually mostly located just near the elbow. It doesn't really go down too much, and it's going to extend and stabilize the elbow. So it doesn't really cause too much. It's not one of the strong muscles that causes actual motion. It's more just stabilizing the elbow to prevent it alongside the ligaments and things to prevent it from dislocating or fracturing there. There's also another muscle. It's sometimes called the paradoxical muscle of the posterior forearm, which is the brachioradialis. The reason why it's paradoxical is because, yes, it's located posteriorly, but it's technically, so its function doesn't match with its location. It's located at the posterior compartment, but it actually performs flexion. And I would highly encourage you, so I've included a diagram at the bottom. It's a bit small, so maybe it's not too useful, but I'd highly encourage you to get one of those anatomy atlases we were talking about. Really focus on brachioradialis and look all the way down at its insertion. So in this section here, it looks like it might cause extension, but if you really focus down there, you'll see it kind of comes up to the front a bit. And then when you pull on it, it's actually going to cause flexion and not extension. So maybe zoom up on that in your studies a little bit. It's the paradoxical muscle. And then finally, the deep layer. So these names are going to be a little bit more different. Again, all these things should be really common to the flexor compartment. You've got extensor pollicis, that's going to be the thumb. The only difference is it has a brevis and longus. Really easy because the brevis will do only like the first and CMC, and the longest will do all the joints of the thumb because it's much longer. Okay. Then you've got extensor carpi ulnaris. So it's the same as the extensor carpi radialis, except it's located in the deep compartment. Extensor indicis. So this is the index finger. So it's going to extend that finger specifically. And these two muscles have a slightly different name. Abductor pollicis longus. So abducts the thumb. I think there was a slide on abduction, adduction, but just again, really think about adduction, what's bringing it closer, abduction, what's bringing it further, abduction, adduction. The hand is sort of a different plane to the rest of the body. So just keep that in mind when you're studying the hand specifically. So those motions might not match up as much. Supinator, again, one of my favorite muscles because it's so easy. It just causes forearm supination and that's it. Okay. It's kind of like the anconius. It's not as large. It doesn't go all the way down. It kind of just sticks in its specific region around the elbow. But again, look at where these are located. Think about when they contract, what will it do? And also look at the name if you're kind of clueless in the exam and don't remember where it is. A couple of extra tips. So I remember talking about, pass, fail for the order of the superficial muscles of the anterior compartment. I also had a bit of trouble remembering the APL, EPB, and EPL because there was actually a slide in specimens once where they focused on a particular part of the hand, like close to this region, which we'll go into later. It's called the snuff box region, by the way, when you come across that. You've got three muscles inserting in there, and they all arise from the forearm. But it's very difficult to figure out which one is which because you might not be able to see where they attach onto. So I remember using a tip called the brevis sandwich, which is one of my tutors went into this. From lateral to medial, it goes APL, EPB, EPL. So you just got the two longest muscles, and between them, you've got a brevis muscle. Okay, that's the way I used to remember it. Another low yield trivia. I won't go into this too much. You've got deep radial branches. You've got posterior interosseous branch of the radial nerve, and they sort of innervate different muscles as well. Remember, interosseous and deep just means it goes even further down, so you might not be able to dissect all the way through to that branch. Another nice summary diagram for you guys to have a look at. You've got the superficial compartment right here. You've got the deep compartment right here. You can see what I mean by anconius. It's really small, right? And it sort of just stays in the elbow region. And then supinator as well is a bit larger, and it's one of the biggest supinators of the forearm, but it's also just staying in that specific region there. Ulnaris is on the ulnar side, and then you've got radialis, radialis going on the radial side. Yeah, so just have a look at these muscles in your own time. This is what I meant by the brevis sandwich. So if you look at the longest muscles, they're on either side. And then in the middle, you've got the extensor pollicis brevis, which is kind of what I mean by the brevis sandwich. We will definitely reinforce this when we go into the anatomical snuff box, when we get to the hand. Okay, now in the forearm, you've actually only really got one region that's of clinical relevance that I'm aware of, which is the cubital fossa. I'm not sure if we went over this last week. I remember just briefly discussing it. The cubital fossa is this region. It's really just like the anterior part of the elbow, like at the front of your arm, right? In front of your elbow. And if you kind of have a look at it, you'll notice that's sort of like a triangular shape. It's an inverse triangle, so it kind of points downwards. And it's got a bunch of different borders, but the borders are not so important. It's more what's inside it that is a bit more clinically relevant. But unfortunately, they can ask you, like, maybe not in the exam, but in specimens, like one of the tutors might randomly ask you, what's the superior border of the cubital fossa? And you don't want to be sitting there thinking about it. Just like imagine looking at this diagram and thinking about what muscles go where. And it's actually really, really simple to remember because the superior border is just a line. It's not a muscle. It's just a line between the epicondyles. Remember epicondyles, those projections on the lateral medial side. If you draw a line between them, that's what makes the superior border. The lateral border over here will be the brachioradialis muscle. So that really long muscle that goes along the side. Then you've got the medial border, which is the pronator teres. Remember, it's the one that sort of doesn't go down too much. and it's going to go from this side all the way down to this side. So it kind of like crosses instead of just going from on one side only. You got the medial lateral border. You've got the roof, which is the bicipital aponeurosis. Really fancy talk for basically just the tendinous insertion of the biceps muscle. So the biceps muscle going down. I think the biceps muscle has actually been dissected here, or at least part of it. But it actually has this tendinous bit that inserts. Remember, I said it inserts into the radius. Another side actually goes down into the cubital fossa, and that's what forms the roof or the top. And the floor is formed by the brachioradialis and supinator muscles because they're a little bit deeper than the biceps and some of the superficial muscles of the anterior compartment. Here's the more important stuff. So the cubital fossa and its contents. There's really just like four major things: the neurovasculature and the muscles or muscle. The neurovasculature is the radial nerve, brachial artery, median nerve. I'd encourage you to actually look at each of these from proximal to distal, so from the shoulder all the way down to the hands, if they reach the hands, and just see what their path is, and you'll notice they all sort of go through that region. I think there was, correct me if I'm wrong, guys, I'm pretty sure the radial nerve doesn't actually technically go through the cubital fossa, like it's a little bit deeper, but that's like more complex than you need to know. Like it's a bit more advanced. Like if you're an anatomy professor, maybe that's cool, but not so much for us. And the muscle is just the biceps tendon. Of course, it's, we know the aponeurosis is forming the roof, but the tendon also goes down and inserts into the radius. So it actually goes into, and you can sort of see that here. It's the tendon inside there that's been cut. I wouldn't remember any of this because there's a really nice mnemonic, which is really need beer to be at my nicest. I've kind of color coded it with each of the, so you've got radial nerve as being the nerve, really need. BA2 is the biceps tendon, which is a muscle. B at, which is brachial artery in orange for the vasculature. And my nicest is just another nerve, which is the median nerve. So as long as you remember this, you kind of know what the contents are. So if they ever say there's damage to the cubital fossa, you know what is at risk of being damaged. Okay, so remember this mnemonic for later. Now into the more interesting stuff. So now that you have a fairly good understanding of the anatomy, we're actually going to try and connect that all together. So all the nerves, muscles, you've got the arteries, everything is actually in different compartments, right? So if I have damage to one section, I'm not just going to damage a nerve. I'm going to damage all sorts of things. So I want to be thinking critically about where each of these things are located. So humerus fractures, let's start with that, because you can actually have them in different regions. The humerus is not the strongest bone, or even if it is the strongest bone, it is one of those bones that is used so much for all these different activities. And you're gonna, if you like just jump off something, you're gonna fall onto it possibly. So you're gonna damage it at all these different parts, at the proximal, mid shaft, or distal. In other words, the top, middle, and the bottom. The proximal fractures we already discussed last week, so I won't go into a lot of detail. You're more likely to damage it at the surgical neck. So recall the surgical neck, you've got the anatomical neck. The surgical neck is not actually like really anatomically defined. It's more for surgery because of the fact that it's damaged the most, whereas the anatomical neck, not too important, clinically that is. It usually occurs in elder patients and usually in people with osteoporosis. So they already have quite weak or low bone density. So it's more likely to damage them if they have a fall. What can get damaged is some of the nerves and vessels that go around the surgical neck. So these are the axillary nerve, which is, if you remember one thing, just remember axillary nerve is to the deltoid muscle. Like there's a smaller muscle, I think it's teres minor as well, that it, yeah, so teres minor, it also innervates. But deltoid, just remember, if you think about what the deltoid does, if you pull on it, it's going to abduct your arm up, right? So if I don't have that axillary nerve anymore, innervating that muscle, I'm going to have really like a lot of trouble abducting my arm. So I'm going to have paralysis there. And I've also got the circumflex arteries, which are not so important, but they're sort of providing blood to the, I think it's the proximal humerus, like the head of the humerus and things like that. So it's not a great place to have a fracture. Okay, you're going to have loss of motion of this sort of part of the shoulder joint. Then you've got the mid-shaft fracture. This one is probably the most important one to remember because we discussed the radial groove, right? We discussed how it conveys the radial nerve. We said it conveys the deep brachial artery. These all travel through the radial groove. So if I have damage in the mid-shaft fracture, like a spiral fracture or something, that radial groove is most likely going to be damaged. So you can see that here. Not the radial groove, but you can see the fracture that's happening. And so if these are damaged, what is the radial nerve doing? Remember that I said common to all the different compartments. It's always at the back. and it's usually just causing extension of all those different joints. So if I don't have extension, what's going to happen is that my wrist is just going to drop. So if I hold it out like this, I'm not going to be able to pull it up and extend it. It's just going to, it's called wrist drop. And you'll see a similar thing in the lower limb called foot drop, which is like another form of neuropathy. And it's also going to cause anesthesia to the distribution of the radial nerve. Again, go back to last week's slides where we discussed the sensory innervation of all the ridges. In between them, you can draw a line. So it's basically just a line above the epicondyles. This is the place where the fracture is most likely to happen of the distal humerus. And it usually occurs due to a Fuchs injury. So falling onto an outstretched hand, that is what Fuchs stands for. And it's usually in younger children. So down on like like this, and then it just like all the force gets transmitted up their arm. When the arm is extended, it usually will damage the median nerve. Again, super, like I definitely encourage you to just look at where the median nerve is to understand what I mean. When it's extended, you will have sort of everything being displaced or pushed backwards. So like the distal part of the fracture being pushed backwards or forwards. And that'll most likely damage the median nerve because it's traveling really, really close to that cubital fossa, right? So if any of these parts move, it can actually sever or even damage or irritate the median nerve. And in other situations, it can even damage the radial nerve. I think you'll discuss the difference in your specimen, so I'm not going to go into that now. And the brachial artery, of course, really important artery because it's basically providing all the vasculature and all the blood supply to the rest of your arm. So if that's damaged, it's going to cause significant blood loss, and it's going to cause all the different parts of your hand to become like blue, right? Because there's not going to be any blood going to it. Okay, so these are the main things that are going to be damaged. Forearm fractures are not so important, really. I don't think I remember having these somewhere in my notes, but I don't think I actually really remembered it because it didn't really come up anywhere. And I don't think you discuss it too much in specimens or imaging. You might see an image of this, but you will never know what its name is in imaging. So these usually happen due to Fuchs injuries and or direct trauma to the region. You've got Monteggia, Galeazzi, Cole's fractures, and Smith's fractures. These ones happen usually at the elbow joint. So this is a really, if you don't remember this, it's okay. But if you remember this mnemonic, which is MUGA, so it means Monteggia fractures, the fractures of the ulna, and the A at the end of Monteggia means that it's proximal. Okay, so it causes a proximal bone dislocation over here. Whereas Galeazzi is G, right? So it's going to be a radius fracture, and Z in Galeazzi means it's going to be near the end, but it's going to be in the distal part. So you can see the dislocation and the fracture happens more distally. So if that's something you remember, that's awesome. If you don't, that's fine. Cole's fractures and Smith's fractures are only at the wrist. And the way I remember this, which was really dumb, and it never actually was useful to me, was Cole is like, if I'm grabbing Cole, right, I'm going like this. So that's going to be when my hand is sort of like extended or my wrist is extended. Smith is just the opposite. So it's when my hand is, or my wrist is flexed. And anytime I just push, I push on this, it's going to cause a lot of damage to that region. And that's all you need to know. Okay, one is outwards, one is inwards. They're not very high yield, but if you just remember these mnemonics and stuff, then you'll be okay just in case it comes up. Elbow dislocation is really straightforward. If you know any kids, or if you have a kid, and you just take that kid by the arms, and the really, really young children, they're not going to have the best ligaments, probably not the best muscles either. What that means is that the elbow joint is already going to be quite weak and growing. It's immature. So if you just take them and you try and like swing them around, right, then it's going to mean that you're going to put them at increased risk of dislocating any of the joints that are responsible for keeping your elbow nice and intact. So you can have radial head dislocation. And it's mostly radial head dislocation just because of the size of that particular bone. But really, if you were really trying, then you could probably just dislocate the whole thing, which is not ideal, but it can be pretty easily managed, I think. And then epicondylitis. You will see this more in clinical skills, but it's inflammation of the tendons that are arising from either the medial or lateral epicondyle. If you have the slides open, I encourage you to also just go back to the slides where there was the summary diagram of all the flexor and extensor, the anterior posterior compartments of the forearm, what you will notice, and I'll just say it, what you'll notice is that the flexor muscles are all going to be attached to one specific side. I believe it's the medial epicondyle where all the flexor muscles are, most of them are going to be having their common tendinous origin. The extensor muscles are typically on the lateral epicondyle, and then they go down to the forearm. So if you imagine you're doing motions which are involving a lot of flexion, you might end up damaging a lot of the tendinous origins of those flexor muscles, and that's going to lead to a lot of inflammation and damage associated with that. There are alternate names for these. So you can see it on the diagram for medial epicondylitis. You've got golf elbow. It's really easy to remember because in golf, you've kind of got like, you're holding your clubs and you're swinging. And what you're doing with your forearm is you're extending it, right? You're like flexing it. You're swinging and you're flexing all your muscles. So it's more likely to cause medial epicondylitis. Whereas lateral epicondylitis down here on the lateral side is tennis elbow, because what I'm doing is it's mostly with backhand. So if someone doesn't do backhand properly, they can get lateral epicondylitis, because in backhand, you need to extend a lot. And if you're not doing it properly, you're going to cause a lot of damage to those muscles, or at least the tendinous origins. So those names really help to understand at least where they're coming from and what motions lead to that sort of pathology. And I think this is the last one. I didn't have anything else to add onto the slide, so I just added in a random quote from a tutor that I had. Olecranon bursitis is really simple. You've got the olecranon bursa. I didn't go into bursae too much because there's a lot of them at all the different joints. They're just sacs, remember, that kind of help to ensure the smooth motion of those joints. There's so many that I probably won't be able to name them all on one slide. Olecranon bursa is a massive one though. So it's located at the olecranon, which is your elbow basically, right? If you were to lean on it for a long time and just sit there, if you're studying, you're writing something and you just have your elbows down on the table the whole time, it's going to lead to a lot of irritation of that bursa and cause it to inflame. So basically don't study too hard. Maybe just get up, have a couple of breaks, or at least don't lean on your elbows the whole time. I don't actually do that. I don't know if anyone else does, but like keep your arms up a little bit if you can, especially when you're typing. So typers have this problem a lot. Okay, so that's olecranon bursitis. And then finally, venipuncture. I think we did go over this last time, but just as a bit of a reiteration of it, remember that you've got your superficial veins. You've got your cephalic and your basilic on the lateral and medial sides. You've got the median cubital, or like I think in American textbooks, maybe in Australian textbooks, sometimes they say antecubital vein. Same thing. It's just a connection between these two superficial veins, and it occurs around the brachial plexus. It's not actually in the brachial plexus, but if you just remember that it is, sorry, not the brachial plexus, the cubital fossa. It's not actually inside the cubital fossa, but if you remember that it is in that region, you'll know what you're going to be looking for, where you should be looking for this vein. We use it for drawing intravenous blood and sometimes even for giving medications through the vein because it'll go straight to the heart. And the reason why we choose this specifically is because it is a superficial vein, right? So it means that it's going to be quite easy to access. And it's also located in a really simple place to find because we know some of the borders. And it's also just right here, right? You don't even need to know the borders. You know it's going to be there. So you can just feel for it and you should be able to find it. So blood donations, drug administration, all happens through there. And that is it on my end. So that should be it for upper limb 2. I'm just going to have a look at the chat because I haven't had a chance to see that. Were there any interesting questions that haven't been able to be answered yet? Or has everything just been answered by the amazing team already? Awesome. I don't think, for the interest of time, I'll just look through the chat later, but I will answer those questions in the chat while someone else is talking through introduction to sensory systems. So I will stop sharing. Thank you so much for your time. And if you do have any questions, you know where to find me.
Easy peasy. Thanks so much to JNAM. So I'm going to share my screen to take you guys through introduction to sensory systems and muscle function. Can you guys see that?
Yep.
Awesome. Alrighty then. Okie dokie. So sensory systems is going to be our first one. And this one's a bit of a short and sweet one, and then we'll go on to muscle function. Okie dokie. So sensation, couple different definitions we need to talk about here. So first of all, sensation versus perception. So sensation is the conscious or subconscious detection of stimuli. So stimuli being temperature, light, touch, all sorts of different things. Perception is the ability to actually interpret that. So we need to actually separate these two concepts in our brain. So sensation is the actual temperature that you feel in your thermoreceptors in your hands when you touch something hot. Perception is the ability of your brain to say, that's hot. So there's two different things happening there. So one of them is happening in your peripheral nervous system, i.e. the actual sensory organs. And that's just receiving the signal. It then sends that to your brain, and only when your brain has a look at it in your central nervous system can you actually consciously understand that or even subconsciously to a degree, but the only way you can understand what something actually means is when your brain has a look at it. So sensation is purely your body taking the stimuli in. Perception is when you actually understand it as heat, light, whatever it is. We then need to also talk about two types of stimulus. So stimulus as an umbrella term, it's things which trigger your sensory organs. The distal stimulus is the actual thing that happens in the environment. So if we're talking about, say, a tree, the distal stimulus is the tree itself. That distal stimulus will produce a proximal stimulus, which is the thing that your sensory receptors actually receive. So photons, for example, bounce off the tree and then come into your eyes. So the distal stimulus is the actual tree. The proximal stimulus are the photons that come to your eyes to provide an image of the tree. And finally, a sensory organ is when we take a bunch of sensory receptors. So you can look at the diagram on the right there. Receptors are just specialized neurons. And they combine those receptors with a larger structural component to give us a better ability to sense things. So the construction of your eyes, the construction of your ears, all of those things serve to enhance your ability to sense things, basically. Okie dokie. So you might have thought you only have 6 senses. You were wrong. You have many, many senses, and they're all modulated by different things. So for many of these, it's quite self-explanatory. So vision, photoreceptors, photo for light, audition, that one's a bit different because there you don't have like an audio receptor per se. You have mechanoreceptors like you find in your fingertips and stuff, but they're specialized and they're only found in your ear. So your hearing is actually modulated by the same basic type of cell as touch, but because they're so specialized and because they're in, again, a sensory organ, the ear, which has a whole bunch of specialized structures dedicated to making you hear, they provide hearing, basically. Chemoreceptors were used for both smell and taste, but they're in different places and interpreted differently. Somatosensation is what you might think of as touch, so we have both fine and crude touch. Now, 3 senses that you might not have an idea of, or sorry, that you might not have considered as senses. First of all, proprioception. So basically, if I close my eyes and I move my arm around, I can still tell where my arm is, and that's because of proprioceptors. So these little receptors, they'll basically determine like your joint angle, your muscle tension, all of those sort of things, to tell you where your body is in, so your position, basically. So you find those in your inner ear for your balance, and also in your muscles and joints to try and figure out how you're posed, basically. Nociception, which is pain. We have nociceptors, so that's just damage, basically. Those are usually found in the skin. So you don't usually feel pain in the normal sense when you have damage to your organs deep inside you, although there are still some nociceptors around the place. Thermoception, so that's heat. So the reason I've separated that out there, sometimes you can group it in a little bit with touch. The reason I've separated it out there is they have its own specialized kind of receptors. So you use a different type of receptor for temperature than you do for, say, touch. Okay, so we've got all these receptors. What do they actually send to the brain? Because remember, we need to send things to the brain if we want to cross that boundary between sensation and perception. So the first type of information that they send is modality, okay? So the important thing to understand here is it's not that the brain can actually tell what receptor is sending in a certain signal. The brain doesn't know where the signal is coming from. It just knows that it comes through a certain nerve, basically. So this is called the labeled line principle. It's like the brain is like one of those old telegraph operators, and it has 10 lines in front of it, and one says, like the optical nerve, and it will say, you know, light information or vision, and then there'll be another one for hearing, taste, smell, touch, so on and so forth. So the brain will interpret all the signals in that line as that stimulus, okay? So it doesn't actually matter where that original signal came from. That original signal could have been, for example, so this is when you start getting painful touch, so sometimes you can have nerve damage. So your brain starts to interpret touch as pain because the touch signal is coming through the pain line. So all it knows is that that line is meant to be for pain. So it interprets it like that. So again, you don't actually have the sensation of pain, but you do have the perception of pain. So that's why we need to separate those things. Okay, location. So you can think of these things called receptive fields. They're sort of like the resolution of your senses. So for example, you have very large receptive fields in your arm, but very small receptive fields in your hands. And what that means is that you're able to discriminate much smaller touch in your fingers, basically. So you have a very small resolution, as in the distance between 2 points that you can tell is different in your hand and also in places like your lips, as opposed to in other parts of your body with much less fine touch, basically. So any receptor within that field, although there may be like, 3 or 4 or more receptors in that field, all of them will just trigger the field as a whole. So you can't actually tell things which are any closer together than that. Intensity. So there's 3 different things that they look at, that the brain looks at when it tries to figure out how intense a stimulus is. So the frequency of firings, which we have a term there for temporal summation. So how often the receptors are firing, how many of the fibers are firing. So are we firing all of my heat receptors or only my heat receptors for my hand? The type of fibers firing. So like muscles a little bit, if you remember muscle summation, in muscles, we recruit the weak muscle fibers first and then the strong ones. In this situation, we trigger the less sensitive nerve fibers first, and then only with a strong stimuli, we can get the strong or less sensitive nerve fibers. So sorry, the more sensitive nerve fibers get triggered immediately. The less sensitive ones, they take more time to get triggered. And finally, duration. So we have 2 types of nerve fibers in terms of duration. So phasic, those ones change really quickly. So just like that, if you have a really quick change in temperature or something like that, then the phasic fibers will immediately handle it and tell you, hey, something's happened. Tonic nerve fibers, they take more time to adapt, but they produce a sustained signal. So the phasic fibers, once we've stopped changing, they basically go silent. Whereas the tonic nerve fibers, they can give us a long-term signal. Excuse me. So phasic fibers allow us to detect very rapid changes, but tonic receptors allow us to tell the duration of a stimulus and can produce a background rate. So a lot of things you're constantly feeling. You're constantly feeling like the temperature of the air and things like that. And that's only possible because of tonic nerve fibers. So here's some diagrams, because I think this is very easy to understand visually as opposed to just me spouting information at you. So on the left, we have phasic versus tonic. So on the top, there's phasic. So you can see it detects the changes in stimulus, but not the sustained stimulus. So this is allowing us to tell that there's a change over time. The tonic fiber adapts a little bit slower, so it's not quite as sensitive to begin with, but it provides a sustained stimulus. So we're able to feel that something is still pressing there. Otherwise, we would only be able to feel when it pressed in and when it came off, which is not that useful to us because we want to be able to tell if something is continually pressing against us. On the right there, we have the sensory cortex. So this is where all of this processing is happening. So all of these fibers, all of these signals are being sent to the brain, and they're being processed right here in the sensory cortex, basically. And you can see they're different resolutions. So your fingertips and your lips take up a massive amount of space, whereas your entire forearm is just there. Okie dokie, on to muscle function. So you've learned a little bit about this already. So I believe you've already seen stuff like this about the structure of, you will use skeletal muscle here. So this will be the first type you look at, and we'll use it. The unit that we'll be actually looking at in this case is the muscle fiber itself. So we're just going to be looking at one cell and how that works, basically. If I look distracted, it's because one of my monitors just died. All good. So the basic muscle cell, we have a few different components which are important to talking about muscle function. So the single muscle cell is just, we call it a myocyte. A myofibril is within the cell. It's a bundle of parallel filaments. So a filament is basically part of the actual part that contracts within the cell. So the cell will have many, many filaments inside of it, and they all make up together myofibrils, and then you group the myofibrils, and that makes up the entire myocyte itself. We have something called the sarcolemma. So that's basically just the plasma membrane of the myocyte. We just have a special name for it, basically. And it forms something called a neuromuscular junction with the neurons, which we'll talk about more in just a sec. We then also have the sarcoplasmic reticulum. So that's a type of smooth endoplasmic reticulum, which is, in this case, not used as a normal smooth ER, but it's used for calcium storage. So it's highly specialized in muscle cells. And finally, we have transverse tubules. So if you look there at the diagram, I believe they're shown in green, I want to say. Yeah, green. And you can see basically the bits where the outer plasma membrane dips in. So it's like a little infolding of the plasma membrane, which allows us to have bits of the plasma membrane which are technically continuous with the outside, but which are deep within the cell. So it allows us to very quickly send a signal deep into the cell. And we'll talk about that again on the next slide. Well, sorry, 2 slides or 3. So lines and bands in a muscle fiber. This is stuff you've already seen, so I'm not going to belabor the point too much. But basically, our muscle fibers are made up of these little filaments here. So we have the thick filaments, which are made of myosin. We have the thin filaments, which are made of actin. And so we're going to talk much more about how these actually work together. And you'll see how the thick and the thin filaments interact. So suffice it to say, you definitely need both. And they both have very different functions in contraction. Okie dokie. So again, actin, that provides the structure of the thin filament. Tropomyosin it's sort of the coil around. You can see there in the diagram to the bottom right. It sort of coils around the actin and it covers up binding sites on the actin filament. Troponin is a little molecule that sits on the tropomyosin, and it's basically a switch. So in the presence of calcium ions, it will pull away the tropomyosin from the binding sites and therefore expose them. And then finally, we have myosin. So it forms the big thick filament. So the thick filaments are sort of the bundle of these long strands of myosin and these little heads at the end, which provide the actual moving force. Okie dokie. So the actual whole process of muscle activation, we call that excitation contraction coupling, because we have excitation, which is the actual signal being passed from the neuron to the muscle cell, and then we have contraction of the muscle cell itself. So the first thing that happens is we get an action potential. So you have thought about moving your arm, for example. The signals have gone from your motor cortex down into your arm, and now they finally terminate with the neuron at that neuromuscular junction. So the axon, instead of terminating on another neuron, they terminate on the muscle itself. So they, like any neuron, they'll then release neurotransmitters, in this case, acetylcholine, that diffuses across the neuromuscular junction, and it binds to sodium channels on the sarcolemma. So it's then going to open them. This is, if you haven't noticed, pretty much the same way that they work on other neurons. There's the same basic idea, where we're turning one depolarization into a bunch of neurotransmitters and then turning into another depolarization. But the depolarization on the sarcolemma is going to be a little bit different. So it's going to spread down into the cell using those T tubules. So you can imagine it's like a big cylinder with a bunch of needles poked into it. And so when the depolarization spreads, it both goes down the cylinder and also down the needles into the cell, which is really useful for us because we want to deal with stuff inside the cell. We then have these little receptors on the side of the T tubule. So they're sort of in between the edge of the T tubule and the edge of the sarcoplasmic reticulum. And they're called DHP and ryanodine receptors. So they're like physically paired, they're joined together. And so they first open the DHP because of the depolarization, and then that opens ryanodine. And that allows calcium ions to leave the sarcoplasmic reticulum. Okie dokie. So we then have a process called cross-bridge cycling. So basically, like I said before, tropomyosin and troponin block the active site on actin. But then when calcium ions are released, the calcium binds to the troponin and pulls the tropomyosin away from the actin and reveals the active site. Okay, so we now have binding sites on the actin that the myosin can use to pull itself along, which is exactly what's going to happen in a sec. So the myosin heads, they hydrolyze an ATP molecule. So they've been waiting for an ATP molecule. Sorry, they've taken an ATP molecule before, but they haven't actually split it yet. So once they split there, they're going to reorient, which allows them to contract. So we're now basically at this point in step 1. Okay, this is a different diagram, so I probably should have kept the same one for continuity of the numbers. But the point is, the myosin then binds to actin. So you can see this is now step 1 in this diagram. And then we have the power stroke, okay? So the power stroke is when the myosin uses a little hole that it's just got on the actin by binding it to it, and it pulls itself along. So the thing that actually moves, well, technically it's all of it, but we're sliding all of these filaments past each other. So you can think of it either as pulling both thin filaments towards the thick filament or pulling the thick filament along the thin filament. It doesn't really matter because they're all moving in relation to each other. But the point is we're pulling these together and therefore contracting the muscle as a whole. Now, after that happens, we release ADP and PI. So there's different steps that happens, but the point is we release both. And the critical thing there is that the myosin stays attached to the actin until we get a new ATP, and the new ATP allows it to unbind, that's going to become very relevant in just a sec. So relaxation. So when we don't have stimulation at the neuromuscular junction, so that motor neuron isn't telling the muscle to contract, we have a bunch of acetylcholinesterases. So again, it's very much like a normal nerve junction. So they take away acetylcholine from the neuromuscular junction, which stops that depolarization signal. So there's no longer waves of depolarization heading down. Those receptors, those physically paired receptors, they both close, which means that calcium ions are no longer leaving the cytoplasmic reticulum. And then we have an ATPase pump. So basically it uses ATP to pump things against the concentration gradient back into the cytoplasmic reticulum. And then because we don't have any calcium left in the cytosol, sorry, they are in the cytosol, they're in the cytoplasmic reticulum, which is within the cytosol, but they're no longer freely floating within the cytosol. But the absence of calcium ions allows that to fall back into place, covers the binding sites, and prevents us from moving any further, basically. Now, remember what I said about needing ATP to disconnect from the actin. That's really about to become very, very important, because in death, because we don't have enough energy, we can't actually bind ATP to the myosin in order to remove the myosin from the actin. Okay, so that means that the myosin stays stuck to the actin, which means that you can't stop contracting. You're stuck in that contracted position. And that's why in rigor mortis, people contract and then they're stuck there until the muscle fibers actually break down, because there's no way to relax them in the presence of ATP. Okie dokie. So sliding filament theory. So the idea is the muscle itself, even though the muscle as a whole gets shorter, right? Nothing inside the muscle is actually, none of the components are getting shorter. They're just getting closer together. So there's a diagram there, both on the top right and on the bottom right. They both show the basic idea. Of that, we, again, have a bunch of things sliding together and reducing the space between them and the empty space in the middle, but we don't actually reduce the size or the length of any of the components. They all stay the same size. It's just the muscle as a whole that reduces in size. So we also have a thing called the length tension relationship, which is basically you can provide different amounts of power in different positions. So the little red and blue diagram is really the best way to understand why this happens. So at the optimal point, all of those little myosin heads we talked about, they're all opposite the thin filaments. So when you have a power stroke, all of them can bind, all of them can pull. That's a lot of power. Now, if you have the maximum length of the muscle, so your muscle is really stretched out, say something like that, there's not much overlap, or even in some cases, there might be no overlap. between the power heads and the actual thin filaments, which means that they can't pull, which means you get no tension, right? You can't pull your muscles apart completely because that would be, you would immediately end up paralyzed as a child if you did that. There's these little things not seen on this diagram, these little springs which join the thick filaments to the thin filaments at the, in like the base of that V. So you can't pull your muscles apart, don't worry. Even if you pull that far, there won't be any, you won't be able to make much muscle power, but you will eventually be able to move it back. The opposite is when we have the minimum length. So we really pull the muscle in really tight, and then we can't get much tension either because there's too much overlap. So we're actually wasting space now. So we want a healthy medium in order to produce the most power, basically. Okie dokie. Then we also have types of contraction, which we'll go through really quick. So there's isotonic and isometric contractions. So in isotonic contractions, the muscle is going to change length but maintain constant tension. So if you're doing a bicep curl at the gym, you're always in tension because you're trying to hold the weight up, but your muscle is changing length. So it's getting shorter, longer, shorter, longer. The opposite of this is an isometric contraction. So we have the same length, but we are changing tension. So if you're like picking up a heavy grocery bag, you might start with your arm fully extended and it finishes fully extended, but there's much more tension on it now because you're holding up the bag, right? So in an isometric contraction, even though the muscle itself doesn't change in length, we'll still have this whole process of cross-bridge cycling, otherwise we wouldn't have any power. But they're rebinding in the same place. So the muscle is not getting shorter, but it is contracting. So it's a bit weird, but try to decouple those ideas in your head. Again, a concentric contraction, it makes perfect sense. The muscle is shortening because it's contracting. But we can also have an eccentric contraction where the muscle gets longer while it contracts. And again, the bicep curl is a good example of how this can happen. So pulling isn't the same thing as getting shorter. So even when in an eccentric contraction, we are like pulling within the muscle, we're not getting shorter, right? So it's almost like you're pulling, but it's not quite working. But within the muscle, you're going to have that whole process of cross-bridge cycling going on. But because of the overall movement, the muscle is still getting longer. Hopefully that makes sense. That brings us up to neural integration and connections. If you have any questions, feel free to chuck them in the chat. But other than that, I'll hand off to Deepak, I believe.
Yep. Just give me a second while I bring it up.
I might have talked a bit fast, so feel free to ask if you need to clarify anything.
Yep, so moving on to neural integration and connections. This topic, it's a little bit convoluted in the lectures because I feel like it didn't structure it that well. So I'm going to try my best to make it as simple as possible. Now, really what we're talking about is controlling movement. And there's three main components that influence movement. So you have your cortical motor areas, which is part of your brain, basal ganglia, again in your brain, and the cerebellum, which is like the small extension part at the base of your brain. Firstly, the cortical motor areas. So you have your thing called your motor cortex, and there are two main areas in which that we're really interested in. So we're interested in area 4 and area 6. So firstly, area 6 consists of your premotor motor area and supplementary motor area, the PMA and SMA. Actually, I think it's just premotor area, not premotor motor area, but basically, in these two areas, we're thinking about what needs to be done before we send the nerve impulses out for the movement to take place. So in the premotor area, we're going to, using sensory information, code the goal that needs to be accomplished, not the actual nerve impulses itself, but the brain is going to figure out what the goal to be accomplished is. So for example, and SMA for the supplementary motor area, that in and of itself has two components, the caudal SMA proper, the rostral pre-SMA. And from the PMA, we the SMA is able to create a motor plan. So SMA is all about creating a motor plan. It does this by using memory in the caudal SMA proper, and in the pre-SMA, that is for acquiring new motor sequences. Yeah. Now, from area 6, we move on to area 4. So area 4 is actually the primary motor cortex. So we just talked about the premotor and supplementary areas, which is about coding and also about the motor plan. Now we're going to actually create the nerve impulses necessary for movement. Area 4 is only active during movement, which makes sense because it's creating nerve impulses for movement. It has low electrical thresholds for stimulating movement, and it outputs down the corticospinal tract, which is a tract that we covered, I think, last time. But essentially, for area 4, you have inputs in from area 6, from the PMA and SMA, and somatosensory areas. And the output is actual nerve impulses. Now, the second one is going to be your basal ganglia. So this is a pretty complex role in movement, and it has a nice little flowchart that will help us understand. But basically, the idea is that at rest, when you're thinking about just resting, your brain isn't actually not firing at all. Your brain is actually hard at work to inhibit unwanted movements. So, for example, you don't want to jerk your hand involuntarily in the air, suddenly turn your head to one side or whatever. And your basal ganglia is important in facilitating the inhibition of unwanted movements. It allows for smooth and fluid movement. So, for example, when you extend your arm to reach out for something, you don't want the opposing muscles to be activated at the same time. So the basal ganglia is composed of 5 paired structures. So you have the globus pallidus, the putamen, caudate nucleus, subthalamic nucleus, and the substantia nigra. Now, the putamen and the caudate nucleus both combine to form a structure we call the striatum. And the globus pallidus has internal and external parts. So it sounds like a lot of new words that I'm just randomly throwing at you, but I just want to give it to you in the context of actually like what's actually going to happen, and I hope it makes a little bit more sense. So just know that there's a bunch of stuff, and now I'm going to explain how they relate to each other. So firstly, we talked about how the cortical areas create signals for actual movement to occur, right? So now from the cortical areas, it enters the basal ganglia where this entire process takes place. Initially, we have a signal to initiate movement from the cortex to the striatum. So striatum, we're talking about the putamen and the caudate nucleus. So something important is that when you see this diagram, there are essentially red and black arrows. So red arrows indicate excitatory stimulus or excitatory excitatory action, while black basically says inhibiting action. So for example, the cortex to striatum in red would be the cortex basically promotes the actions of the striatum, while striatum to GPI SNR would essentially mean the striatum is inhibiting the actions of the GPI and SNR. So black is sort of like inhibition, red is excitatory, and you have 2 different neurotransmitters that facilitate it. So you have in black, you have your GABA, and in excitatory, which is red, you have your glutamate. But first, I want you to orient yourself. So we have the cortex here, signal to initiate movement from the cortex to the striatum. And since it's basically excitatory for the striatum's action, it's telling the striatum to do what it wants to do. And the striatum wants to inhibit the GPI and SNR, the globus pallidus internus and substantia nigra. So the excitation of the inhibition causes the inhibition of the GPI and SNR, and this allows it basically silences the normal inhibition to the thalamus that it has. So by inhibiting the inhibition, you promote the thalamus's action. The VLO is basically another name for the thalamus, by the way. So basically, cortex promotes striatum's action, which is to inhibit the GPI and SNR. And inhibition of the GPI and SNR basically silences the silencing of the thalamus, and it frees the thalamus of inhibitory movement and enables movement to occur. So it causes the action to actually take place. Also, I mentioned I sort of skimmed past the word tonic here. Tonic essentially means the constant firing. So this will constantly want to inhibit it at rest. So say these signals are coming in, it will act to inhibit movement, essentially. This is sort of what it looks like more accurately when it comes to, I guess, the way it's structured in the brain. You can correlate it and sort of see that it makes a lot of sense. Okay, so now the initial pathway is this rectangular one, which is the direct pathway. And in this pathway, we end up starting with signals from the cortex wanting to do stuff, and we end up inhibiting the thalamus. Not inhibiting the thalamus, which allows us to continue and actually have that movement, right? Now we're going to go to the indirect pathway, which is another pathway down this tract, which ends up in us inhibiting the movement. So the indirect pathway has net suppressive effects on the cortex. So now cortex sends signals to the striatum. This time it's going to go down this alternative route. The striatum is going to silence the globus pallidus externus. And the silencing of the GPE silences its normal tonic silencing of the subthalamic nucleus, the STN, so the silencing of the silencing causes activation of the STN, which then causes activation of the GPI and SNR. What this convoluted process ends up with is essentially the action of the GPI and SNR happening, which is the tonic silencing of the thalamus, which ends up with a silenced thalamus or inhibited thalamus, and we essentially end up inhibiting movement. So yeah, it can take a couple of look-throughs to wrap your head around it, but it is pretty cool. The third thing, which is the cerebellum. So we talked about the cortex, the basal ganglia, now it's cerebellum. The function is really to make smooth movements, and the signals from that initiate movement pass through the cerebellum before entering the body. The cerebellum gets sensory input from the general position of the body and uses it to coordinate movement. So you get smooth movements of balance and equilibrium. So if you look at this diagram here, the motor plan moves through the cerebellum, and depending on the sensory input the cerebellum has, it can adjust the motor plan and coordinate that movement. The sensory input that the cerebellum is getting is from the muscle spindles, which we'll talk about in a second, which is essentially receptors that sort of allow for proprioception, which James briefly mentioned, I think, which is essentially your position in space. But yeah, talking about the structure of the cerebellum. So there's a couple of different ways you can approach it. So you can think of it in terms of the anterior lobe, the posterior lobe, and the flocculonodular lobe, 3 main lobes. Another way is from a more, I guess, this is a sagittal section, this would be more coronal, but you have a central part, which is the vermis, and you have 2 hemispheres on the opposite side of the vermis. So, and in these 2 hemispheres, you have an intermediate zone and a lateral zone. The lobes still stand, so you can see on this diagram how you can still separate it in terms of the anterior lobe, posterior lobe, and the flocculonodular lobe, but this is another way to think of it. So the reason why we have different ways to organize structure is because we can think about function in a different way as well. So for example, the vermis it controls movements of the axial body, so not of the appendicular body, not of the legs and arms, but of the neck, shoulders, and hips. The intermediate zone controls, the intermediate zone of the hemisphere controls contractions of the distal, upper, and lower limbs, while the lateral zone has a separate function, which is to essentially have overall planning of sequential movements together with the cerebral cortex. So this is about timing and coordinating movement. So loss of the lateral zone would cause movements to lose timing and sequence, so you'd end up being uncoordinated, or you do actions in the wrong order, sort of thing. Okay. So again, this is another sort of way to combine function and structure. So the flocculonodular lobe, the functional equivalent can be called the vestibulocerebellum. And this coordinates the trunk and proximal joints. You can see the spinocerebellum here, which basically is the vermis and some intermediate zone, which coordinates the distal portions of the limbs, and the cerebrocerebellum, which is formed by the lateral hemispheres, which plan sequential movement. So it's slightly different to this this way of organizing and seeing things, but it's another way to combine function and structure. So I wouldn't get too worried about all these kinds of stuff because it was taught to us, but we never really went into that much detail afterwards. But something that's important is this stuff, which is neuroplasticity. So essentially, when you have impulses that travel down your corticospinal tract to your muscles, repeated activation of that tract causes changed excitability. So when people, I guess gym bros and people who exercise a lot talk about it, something they say it's a mind-muscle connection, and it really is a neuromuscular connection which results in greater recruitment of fibers, which leads to greater strength in total. So really, in order for you to have the impulses travel down to your muscles, well, you can actually imagine and do the exercise, which would activate similar areas in your brain. And this would cause significant strength increases. So for example, in the trained limb here, imagining causes a 22% increase, while people actually did the contractions, it caused a 30% increase. It's quite significant. Now, the question now is, can we train one limb and have strength improvements in the opposite limb? The reason why that's even a question in the first place is because unilateral movement causes increased corticospinal activity of the contralateral inactive limb. What that means is unilateral movement is the movement of one limb causes activity in the brain of the opposite limb that is not actually moving. And this suggests uncrossed ipsilateral fibers. So it's, yeah. However, what we understand now is that there's not enough uncrossed fibers to increase strength bilaterally. However, for people who are in, I guess, in a setting where they are trying to get back to their body to working condition, probably after an accident or whatever, we now know that unilateral resistant training maintains strength of a contralateral immobilized limb. So it may not cause increased strength, but it can maintain the strength of an immobilized limb, which is pretty significant finding. And that is the end of my part. If you have any questions, please chuck it in chat.
Right over to me now. 1 second to screen share. Apologies for the lip snacking. I've just been snacking. All right. Ask someone else to present if Zoom repeatedly quits. unexpectedly.
Do you want me to do it for you? Kyle?
Yeah, that might be good. It's crashed twice already.
Sure, no worries.
I'll just stop sharing. Ah.
I might have to manually stop your share. Okay, there we go.
All right, I'm back, and thankfully Jenel's screen sharing. So yeah, what I'm going to be talking through is just a general overview of the key ideas and the patterns that you see in musculoskeletal examinations, whether that be upper limb or lower limb, regardless of sort of what joint you're looking at. So onto the next slide, please, Janelle. All right, so these are the key ideas. Most importantly, use your ClinSkills booklet because it has everything that is examinable on ClinSkills really in it. And it has everything you're going to need to know and that we're going to need to know at the current level, at our current level of understanding. So the general process of seeing a patient is you take a history and then that's including your systems review and all of the history aspects down to social history. Then you progress to an examination. So you've developed a differential diagnosis, probably a bit of an idea of, okay, these are the things that we should look at in your history. For instance, if someone is a tennis player, then they might have a higher risk of tennis elbow, for instance, which is a condition, a musculoskeletal condition there. And so you might be thinking, okay, well, now we need to start examining the elbow, for instance, for that. And so you'll progress to the examination. Then after that, for instance, if you aren't entirely sure or you need to get more information, then you would progress to investigations. So those are the sorts of things like blood tests or an ECG, things that you usually send off or use a machine to help measure. And then after all of that, ideally, we've reached a diagnosis for a patient. But today, what we're going through is the examination, specifically of the musculoskeletal system. So the general process of an examination, you do the steps of an introduction, which I'll go through in a little bit. Then you assess the patient's general appearance. So does it look like they're sort of stumbling around, or are they visibly agitated, things like that? And then you progress to the specific targeted examination of the area that you want to examine. So usually a joint or a region. And that takes the next few steps in italics. So initially you look, you perform inspection, then palpation, which is a fancy word for touching and feeling the actual region, recognizing all of the landmarks and noting any abnormalities. Then from there, you go to movements, which is where you're actually moving the joint. And firstly, you get the patient to do it, which is an active movement. Then you do it passively. So you tell the patient, oh, don't move the joint yourself, just let me move it. And then you perform the movements for them, and that's to assess different things. Then we progress on to measurements, if that's relevant, and some of those you'll do during movements. So I think as we're going to see, and as we may have seen a little bit already, for instance, abduction of the shoulder joint or abduction of the arm, that has a normal range of movement of, I think, 180 degrees when you're including the shoulder joints as well, and the scapula. So you might be noting, okay, well, is it limited? Can they not go as far? Because, for instance, maybe they aren't able to recruit the deltoid, or there's some pain in the acromial region. Anyway, that's the general idea, is you'll be measuring things like approximating range of movement, and also, oh, have they been wasting muscle? So has there been muscle wasting? Have they lost muscle mass? And usually you'll be able to tell that because you've been taking measurements over time, or because it's very different from one side to the contralateral opposite side. Okay, after measurements, then you've got special tests. So that's the specific things to a specific region. And I think Janel and Janam will demonstrate those a little bit later for the shoulder. Final key points, practice. So the more that you practice these sorts of examinations, the more you'll start to go, oh, okay, so after this, I do that, and after that, I do this. And you'll be able to develop a bit more of a feeling for it. You'll start to sort of internalize the idea of, okay, it's inspection, then palpation, then movements, etc. Another key idea, you want to compare sides. So for things where we have bilateral structures, bilateral symmetrical structures, like both of our upper limbs, for most people, obviously there are exceptions, then it's important that we compare, okay, well, does this arm have anything that's different to this arm? And one of the obvious ones will be handedness, which was something you'll ask about in the history. But in terms of actual physical differences, is there a lump somewhere on one arm, or does there seem to be an obvious rash on one side, or has there been muscle wasting on one side? That's sort of a great way to check abnormalities. When you're doing the examination as well, and when you're comparing not only inspection, but also movements and things like that, if you're going to do it one at a time, then do the unaffected side before the affected side. So if someone's thinks they might have dislocated their shoulder, for instance, then you probably, one, want to be quite careful in how you're examining that. But two, you want them to be performing whatever examination step with their arm that there isn't a problem with, or that they aren't suspecting a problem with, before you progress to the one that you suspect there might be a problem with. And that's to see the normal, and also because you'll be able to sort of measure the how severe this may have gone. Anyway, I'm getting encouragement to speed up a bit. And yeah, as you're taking the examination, don't do it silently. Don't breathe down the patient's neck, just ominously. Talk through it, tell them what you're doing, explain it to them in layman's terms, and yeah. All right, those are the key points. That was going to take up a decent bit, but now I'll just speed run through the next bits. All right, on to introduction, please, Janelle. Okay, so with the introduction, this is like your history. Similarly, so you're doing hand hygiene. You're introducing yourself. Hi, I'm Kyle McKinnon. I'm a second-year medical student at Monash University. Explaining the exam. So what are you actually going to be doing? Inform them of what exposure is going to be necessary for the exam. So in this case, they're probably going to need to remove their shirt. Or if, say, they're doing the shoulder, you might just be like, okay, well, maybe if you feel uncomfortable moving your shirt, maybe we can just do that, or something that enables you to get the most exposure while very much ensuring that the patient is comfortable and that they are consenting. Because you don't want to breach the autonomy of the patient. That's very important. Okay, confidentiality. So explaining to them that it will be kept, any findings will be kept confidential between themselves, yourself, and the rest of the treating team, if relevant. And then just ascertaining, have you got the right patient? Are you going to start examining a joint that the patient doesn't have because you've got the wrong patient? Something like that would be less than ideal. And ask the patient if they're in any pain or discomfort, because that will enable you to sort of target the examination and avoid causing them harm. And then for an upper limb examination, that you're going to have them standing up and mentioning exposure again, upper half of body exposed. Okay, so on from introduction, onto general appearance. So here we're just looking at the holistic view of the patient, their entire body, and we're just seeing, okay, well, does it seem like they've lost a lot of weight or gained a lot of weight? Does it seem like they are very muscular, not particularly muscular? And then also, does it seem like they're uncomfortable? Does it seem like they're in pain or distress? If they seem really agitated, then that's very important to note. And very important as well for you to make sure that you feel safe as a med student in this scenario. You obviously also have to consent to what you're doing. Also, are they in an abnormal position? Have they got their one shoulder up because they're trying to cradle their arm because something hurts? All right, on to actual specific inspection, please, Janelle. Okay, so that's where you're looking at the region and you're looking for, once again, abnormalities. So abnormal gait, which is the way that they're walking, or posture, which will also be more relevant when we get down to lower limb as well. Skin signs, so does their skin look different to the surrounding skin or to what they normally expect? Yeah, are there any other sort of deformities in shape or size? Has there been subluxation? So subluxation is when the joint has been not dislocated, but it's out of position, but it's still in contact. Whereas dislocation is when there's been a disconnecting of two bones or the normal connections of a joint. And muscle bulk or wasting, as I mentioned earlier, and very important to compare sides. All right, on to the next bit, please. Palpation, that's the touching, feeling, hand on skin. So you want to start off gentle and go firm if you're palpating things, because you don't want to hurt the patient. You want to start gently and work your way. If you need to palpate a bit deeper to feel a specific bony landmark, then work your way into it. Don't just immediately poke as far as you can through all of their soft tissue. It probably will be a bit jarring. And so for that, as you'll learn, you go through and you identify key bony landmarks in surface anatomy. You feel for the temperature of the region, because if it's hot, then that might indicate inflammation. So there could be an infection or some other sort of inflammatory process going on there. Tenderness, so that's where if on palpation, so on touching or on pressure, it causes the patient some pain. So that's obviously very relevant to your findings. Synovitis is inflammation, itis, of the synovial capsule. So that's the joint capsule with the synovial fluid in it. And that has what is described as a boggy feeling. I've never felt synovitis in person, so I don't have a bunch to add to that. And so on and so forth. The slides are there, and they're also in your clinical skills. Like I'm taking most of this from your clinical skills notebook, which is your the most important document for clinical skills for you and for us. All right, on to the next one, please, Jenna. Okay, so movement, as I was saying earlier, you get the patient to do it first, then you move it, because if the patient is experiencing pain in a certain way, then you probably don't want to be overdoing that on them. And on top of that, it shows their actual ability. So it shows how much function they have compared to range of motion. All right. Then passive, they move them. You move the joint in sort of some slightly uncomfortable directions to see whether it's stable. And you also check for crepitus. You note crepitus if it's there, and that will indicate some wearing of cartilage. Measurement. On to the next one, please, Gina. Okay, so with measuring, yeah, the two things you measure are range of movement, range of motion, and muscle bulk, which I mentioned earlier. And the way you do that is the circumference around whichever muscle, 10 centimeters from the relevant joint. Okay, special tests. You'll see some examples today, just after this with Janelle. And for example, you've got the shoulder apprehension test. So that's where you're pressing this way. You'll see it in a minute. And then you conclude the examination. So you say, thank you for participating in this, informing them that this will be passed on to the doctor and all of that. You ask them to dress and you tell them what you found. So if everything was normal, then say that everything was normal. If there was something that you noticed, then tell the patient it's their body, they shouldn't be informed, and perform hand hygiene. All right, thank you very much.
All right, thank you, Carl, for that amazing overview of the clinical examination of the shoulder. We're now going to move on to some actual practical demonstrations of how all that works. So we're going to start off with, again, a quick summary of what Carl said, but I won't labor on it too much because we've already talked about it before. But essentially, you're going to be asking first, getting the exposure and the consent you need. You're going to be doing a little bit of looking around the joint. You're going to feel around the joint as well, move and measure with the patient, and do a couple of special tests as well, which we'll show in a second. And you'll be doing a lot more of these examinations with other systems in year 1 and year 2 as you learn more and more of these systems. But for now, we'll just focus on the shoulder. So I won't talk about this for too long because, again, Carl has mentioned this already. We'll skip straight on to the actual examination itself, starting off with the ask point. So you notice that under each slide, I've also got some examples of a script you could use, but I don't want you to have to follow it word for word. Use it as a sort of guide and modify it for what works best for you, and try to really establish patient rapport when you're doing so. Yeah, so normally what I do is I'd say, hello, my name's I'm a first year medical student from Monash University. How are you today? Can I grab your name, age, and date of birth? How would you like me to address you? Like all the introduction stuff. And then say, thank you. Your GP asked me to perform a brief physical examination on your shoulder, which will involve me asking to remove your shirt, so explaining the exposure there. And then saying that you're going to take a look and feel around the shoulder, and then have a look at the movements around the shoulder as well. And then asking, are they okay with that? Getting their consent. And then once that's all good and done, say, great, and please let me know if you're feeling uncomfortable or in pain at any point, and we'll just stop. Again, just signposting that you're trying to make a comfortable environment for them, and you're not going to force them to do anything which they're not comfortable doing. Next up, we have the look component, which again was already mentioned, so I won't go into it. But in terms of actually wording it, you might say that you might be speaking to the examiner or the GP who is supervising and say, Mr. Shah has normal posture, no visible signs of pain, no visible deformities, injuries, and so on and so forth. Basically just saying whatever you can't see. In most of your patients that you'll be inspecting in year 1 and year 2, you'll not see any of these signs. So all you have to just say is, I'm not seeing any of this. All right, and now moving on to the actual physical component, which is feeling and palpating on the patient. So we start off with temperature. Temperature you normally feel with the dorsum of your hand, so the back of your hand. You place it on the patient's skin, for example, and just feel what the temperature is. You do it on both sides, usually at the same time, and compare between the 2 different joints, just to see if there's a difference there. And that will normally indicate to you that that's something you want to note down. But otherwise, you might just say temperature is normal and similar on both sides. Then you want to look for swelling and muscle bulk. So again, as Kyle mentioned, you can directly measure that, or even just feel or see that muscle bulk there, and just note it down as either a swelling or a muscle bulk, whichever you think is more relevant, depending on how it feels if you touch it. And also note down if there's any tenderness upon palpation. So if you're touching a particular area on the patient, they might actually feel a little bit of pain. That's called tenderness. So when you palpate it and they feel pain, it's called tenderness. And you want to note that down as well and let the examiner know that you've seen that. All right, so it's good to have a systematic way of actually feeling around the joint. So one thing that we normally encourage is using surface anatomy landmarks. That is, when you're feeling around the joint, try and go about systematically. So I'm going to try and demonstrate on Jainam here. And I haven't asked him to remove his shirt just for the purposes of this examination. But what we would normally do is we'd first of all start in the middle, in the chest, which is the sternoclavicular joint. And you can normally feel it on yourself as well. Just about here, you'll feel like this little bony ridge there, which is that sternoclavicular, the joint there, right? And you want to normally start there. And then from there, you'll move on to the clavicle, which is just about there. And again, you can see on the diagram right there, it's just coming off over here. So feel along the body of the clavicle, then go to the edge of the clavicle where it's meeting with the acromion process of the scapula, so the acromioclavicular joint, and then so on and so forth. You want to feel the greater tuberosity, lesser tuberosity, the intertubercular sulcus or the groove. You also want to feel the coracoid process, which is actually this sort of very prominent process you can feel if you really deeply sort of push into your shoulder, just medial to your humerus, I'd say, and a bit above as well. And with the scapula as well, you want to go to the back of the body and feel the spine of the scapula, which is normally you can see quite well just from on sort of thinner patients, but also you can feel it as a very prominent bony ridge there. And then you also want to feel the medial border of the scapula, which you can just dig into and sort of feel, of course, being careful that your patient's comfortable the whole time, and also the angled inferior border of the scapula as well. And I've got a legend down there as well for you to refer to in terms of if you're sort of confused about what all these numbers mean. So come back to that once you're confident with the anatomy of the shoulder. And in terms of movements, now I'll get Jadam to actually come in here. So just come along and we'll talk about the movements of the shoulder joint. So we already demonstrated all of this to you, but we'll start off with flexion. So you'd ask your patient to flex the shoulder joint. So Jadam will go ahead and do that. And you can't really show all of it on camera, but you should be able to get 180 degrees of flexion all the way up to the vertical point. And then you have extension, which is doing the opposite and going backwards. So it's like tilt that way as well. So you can see that it's about 65 degrees-ish. Again, not easy to show on camera, but it is pretty much just about that range.
I might interject for a second, Janelle. The blur function is making Janelle very blurry.
All right.
I look like a ghost.
All right, let me remove that then. Is that better?
That's better, yeah.
So
Okay, perfect. Yeah, flexion is there and extension is the other way around. Internal rotation, you can normally do it in multiple ways, but the most common way is you get your patient to come out like this and you move the arms in for internal rotation and then the arms out for external rotation. So quite simple, often called the innies and outies, but the ranges are again given there. You also have abduction and adduction, which is moving your hands out away from your body rather than in front of or behind. And again, the ranges are shown there. I think with abduction, it should be 180 degrees instead of 90 degrees, but I'll correct that. And yeah, we'll sort of talk about that more as well.
I think the 90 degrees, sorry to interject, but the 90 degrees is when your scapula isn't like contributing to the movement, I think. When your scapula comes in and you're actually rotating the scapula alongside your humerus, then you can go the full 180 degrees. So I think when you're doing passive movement, I think if you're doing passive movement, you want to just get it to 90 degrees until the scapula, you want to feel the scapula as well to prevent it from moving at the same time.
But you should be able to see the patient be able to do all the way up to the top of the head as well for abduction. And you also want to note something else extra here as well, which is called crepitus. Sometimes when patients are doing certain movements, you can hear a grating sensation, which is what we call crepitus. And so we just note it down as either there is or there is no evident crepitus upon movement. And yeah, we'll move past that swiftly. And now we come to the interesting bit, which is special tests. So I'll get Jen to perform this as well. So we'll start off with Apley's scratch test, which is actually a really useful test for just evaluating general range of movement on your patient. So what you can do is, could you just reach your shoulder, Janam, and reach it from the other side? And you can do it from the front and from the back. So like that, yep. And then also with your hand on your back like this, could you reach the shoulder as well? The second one there. Yep. And the reason we do both these movements is that they're each evaluating two sets of movements in themselves. The first one on the image there is evaluating abduction because you're abducting your arm and then externally rotating it, right? To move it sort of externally rotate it and move it there, right? So you're going out there to reach over and touch your shoulder. So that's why it's useful to evaluate both those movements there. And the other one is adduction and internal rotation. So if there's pain on any of these movements, you know that one of these certain movements you could investigate further with the other special tests, and we'll look at those as well in a second. So again, a very, very useful way to just get a general idea of the patient's range of motion, quick and easy to do, and it sort of tells you what to do next as well. So next, you have near sign and Volkman's test. All right, so near sign is just this idea where you ask a patient to twist their arm in, so sort of internally rotate their arm, and then to raise it to the roof, right? So Janam can demonstrate raising it to the roof. And you normally have the physician coming in and actually helping to physically move that arm up because normally the patient will feel pain when they try to do it themselves. So the physician just comes in and moves the arm up, and then you stop at the point where the patient feels pain. And again, that's assessing certain muscle groups in that area, which are responsible for flexion of the arm at that joint, the shoulder joint. All right. You also have Hawkins test, which is a little bit difficult to explain. But again, once you learn it once, it's really straightforward to apply. Basically, you place your arm on the patient's shoulder, so like this, right? And then you get their other arm and lay it on your outstretched arm like that, right? So kind of like a lever. It looks a bit strange and a bit floppy at the moment. But what you do from there is then sort of pull down their wrist, right? And you can see by doing that, you're sort of moving the arm at this area by pulling down their wrist. And that again is going to be a useful test to, we're not going to go into the clinical relevance just yet. We're going to be tying that in later, but that's going to be a useful test to test a number of muscle groups that are responsible for the internal rotation of the arm.
I just wanted to add there. I'm sorry, I'm sure you'll get to it. But with both Nears and Hawkins, they're both ways that you internally rotate and flex the shoulder, and that's usually used to assess for like subacromial bursitis or impingement there.
Exactly. Yeah. Perfect. And for special tests as well, we have another one here, which is a painful arc test. Probably the easiest one to do. Basically asking the patient to essentially abduct their arm, right? On their own as well. So they're going to be doing all on their own, and they sort of tell you when they feel pain, and certain angles where they feel pain correspond to certain pathologies. They're not absolute rules, but they're very good to start getting an idea of what might be going on at the shoulder joint. And I know I'm going a bit over time, so I'll try and keep it quick, but you also have the biceps function and the apprehension test. Again, with all these tests checking for pain, right? As soon as you see pain, that's a positive sign, and you want to note it down as being important. So start with the biceps function test. As shown on the diagram, it's very simple. Get your patient to have their arm out like that, and you want to pull down on that arm and see basically if they're getting any pain on resisting that movement, right? If he was getting any pain, I would note it down and say that he's having sort of pain on flexion at the elbow joint. But it also sort of indicates that that muscle that starts from the shoulder, right, and comes down to the elbow is potentially affected. You also have the apprehension test, which is on the right there. It's a bit more different to the previous one, where essentially you're not just like resisting the motion and trying to look for pain. You're trying to look for physical signs of discomfort on the patient's face. So it's kind of important to angle yourself in a way where you're doing the test, but also trying to get a look at the patient's face at the same time. So what I do is I get Jainam to abduct his arm and then externally rotate it like that. And then I put one arm on here on the back of his, I'll go like this actually, so you guys can see it, maybe like that. One arm over here, right? And then one arm over here. And that will basically stabilize his lower arm. And this over here will apply a force to his shoulder, right? And I push on it. And when I'm looking at the patient's face and I see a sign of discomfort or apprehension that there's something, something's going to fall loose, or they might actually describe feeling it as if they feel that the joint's going to pop out of its socket, then you obviously want to stop there, but also want to note it down as a positive sign. You don't want to go in and just ram into their shoulder with immense force, but you want to use a decent amount of force to try and elicit that sign. Okay. And again, something you'll be getting used to the more you practice with it as well. And finally, we have the rotator cuff tests, which are probably the most interesting ones because they're testing the individual rotator cuff muscles, which is something you'll actually find is very common to injure, especially in overhead athletes who play baseball, for example. And so what you do is you're testing the movements that each of these rotator cuff muscles is responsible for doing. So we'll start off with the supraspinatus test or Job's test, which is called the empty can test sometimes. And the idea is you get your patient to have their arms outstretched, flip them around, so internally rotate them, and then you push down on their arms like this, and they have to resist that movement and push back up. All right, and that is testing supraspinatus because it's sort of both external rotation is being performed there, but more importantly, supraspinatus is responsible for a little bit of flexion at the shoulder as well, or abduction of the shoulder as well. And so those sort of things are being tested by that test when you're resisting that motion. And if that patient has a tear of that muscle, normally they'll get pain because you're trying to really force that muscle to work and oppose that motion. Next, you have subscapularis or the liftoff test, which Jainam is showing here as well. You get the patient to put their arm on their back like this, and then you sort of put your arm on their palm like that, and you ask them to sort of push on your arm. So resisting your pushing, right? Again, it's a resistance test. And if they do have infraspinatus injury, a subscapularis injury, my bad, they're going to experience pain on that movement. And again, this is because what you're doing here is internal rotation, right? And you're trying to get them to, I guess, bring their arm back around almost with that lift-off test, which is using the subscapularis muscle to pull on the arm from the front and sort of push it, rotate it around forward. And if that muscle is injured, as soon as they start sort of lifting off or pushing on your arm, they're going to feel pain right in the subscapularis muscle right there. And you can note that down as well as being a notable finding. And then finally, the last thing you have is the infraspinatus test, which is shown on here as well. You get your patient to just put your arm out like that. And what you're doing with infraspinalis is, again, it's a rotator cuff muscle, but it's more so responsible for external rotation. And so they'll be trying to externally rotate, and you'll be resisting that motion by pushing back on them. So something like this, maybe, right? Of course, it depends on how you're oriented, but that's just testing that movement of external rotation. Again, if they have a tear or an injury to that muscle, there's going to be pain there. And finally, I know it's a lot of stuff to go through, but one thing that I found useful was writing it all down on one page when I was learning this stuff. So I've sort of made a little bit of a summary sheet, which you can, it's sort of a one-page summary sheet, which is going through systems review and the physical examination, which I tried to make last year. It's a little bit messy, so some things may or may not be there. But we should be linking that as well in the drive, and you can take a look at that. I recommend that whenever you're doing the examination for the first time, just have that ready so you can look at the diagrams and see what to do. And then from there, just try and see if you can do it all on your own. Great, so that's basically all I had for physical examination, and I'll let Jane go and we can end it there.
Perfect. So thanks so much to Janil and his assistant Jane. And thanks to you guys for sticking around. I know we're about 10 minutes into the muddiest point thing. So obviously we're learning with the new format and the heavier semester 2 content. So we'll try and stick it closer to the like 2-hour mark in future. I think we're pretty close to it in the beginning. We started a bit late today, so hopefully we should fit within that spot. You can always catch the last bit of it on YouTube, because as always, we upload it usually the day of or the day after. So don't be afraid to catch up there. But yeah, I'll upload the summary sheet that Janelle mentioned to the drive, so you can find it there. It'll probably be under additional resources or something in the SEM2 folder. So you'll be able to access that. And yeah, thank you to everyone who sent us Curious Cat questions, much appreciated. Please keep using that. It's a really good format to publicly send stuff. I know there are a couple in the backlog right now, so we'll get to answering those as quickly as we can. Thanks so much. See you next week.